This next group of drugs are the what's deemed the inhibitors of intestinal sterol absorption, and really it's just one drug. It's under the brand name Zetia. The trade name is ezetimibe, which I can never say, and basically this binds to the Niemann-Pick transporter, the NPC1L1 transporter. This receptor, this transporter, is on the luminal side of the enterocyte, and basically it inhibits the absorption of phytosterols as well as cholesterols from the intestines. And you can also see a reduction in LDL. And so this is great because this drug is effective even in the absence of dietary cholesterol, since it blocks reabsorption as well. So regardless of what the patient eats, we're also blocking cholesterol reabsorption. Because remember, cholesterol gets circulated and repackaged because it is kind of the building block to hormone synthesis, and so there's constant cholesterol turnover outside of nutrition. So this is another drug that's enterohepatically recirculated. So there's kind of a high, kind of a first pass effect, which is great because that's where the predominant target is in terms of cholesterol recycling and so forth. The majority of the drug is excreted in the feces. This drug is typically given in single daily oral doses. There might be an increase in triglycerides, and so of course you kind of have to monitor that. But the average reduction in LDL is between 18 and 20%, which is pretty, which is pretty good. And so what we like to do is actually combine this drug, Zetia, with other drugs that can reduce LDL, specifically statins. And so when you combine them, they work synergistically, and you can kind of get an additional 25% or so reduction in LDL over than just using the statin alone. So an example would be like if you want to reduce, say the patient had really high levels of LDL, and your target was to reduce LDL by, I don't know, 75 or 70%. Well, I think the maximal amount of LDL that you can accomplish in terms of reduction with a statin would be about 50-55%, even say 60%. What you can do is you can combine ezetimibe or Zetia to get that extra 10 or 15% reduction in LDL. And so you'll see sometimes these two drugs given in combination. There's two, as far as I can remember, there's two brand name formulations that have ezetimibe plus one statin co-packaged into one capsule or one tablet, so the patient's only taking one drug and or one medication, and they get the benefit of both drugs being co-administered. There is some data that shows patients that can experience some toxicities if they have some type of hepatic insufficiency, but it's a low incidence. And so really the most commonly encountered side effect or complaint is kind of gas or upset stomach, which compared to some of the other drugs that are out there really isn't that bad. Of course, when you combine it with the statin, you can obviously have the side effects of the statin, which could be muscle soreness, muscle weakness, and so forth. All right. The second group of drugs that are kind of new include these monoclonal antibodies to PCSK9. These are called the PCSK9 inhibitors or blockers. And it's a monoclonal antibody, and it's really kind of designed for the patients that have this autosomal kind of dominant hypercholesterolemia. These patients have really high LDL levels regardless of what they put in their mouth and eat. They can have xanthomas, and they're typically associated with early cardiovascular disease. PCSK9 is one of those matrix-type proteins or an extracellular protein that's secreted by the liver, and it's kind of a key regulator for LDL receptor activity. When PCSK9 levels are high or there's a gain of function of the protein, the LDL receptor expression can be kind of reduced, and that causes a spike in LDL levels in the serum. So this is kind of a great drug for those high-risk patients who actually cannot tolerate the high-dose statin that's currently recommended in the guidelines. And then, of course, the final group of drugs include your omega-3 fatty acids. Technically, they're a natural source. They're not a drug, but there is one drug that's actually formulated to be omega-3 fatty acids. It's Lovenza. But basically, patients can kind of self-medicate by eating foods that are rich in fatty acids, omega-3 fatty acids in particular. Think kind of your Mediterranean or your Japanese diet, so fish, sushi, seafood. There's lots of omega-3 fatty acids in those kind of saltwater marine organisms. Clinical trials really showed a nice reduction in in a whole host of cardiovascular associated pathologies. You can see a reduction in triglycerides. I'm sorry, this should be TG, not TH, triglyceride. Reduction of triglycerides by up to 25%. You can see reductions in platelet aggregation, so it's part of the the healthy diet for the heart patients. A reduction in the incidence of arrhythmias. And in terms of side effects, there's very few. Basically, maybe some upset stomach, especially if how the fish is cooked. In the case of sushi, it may not even be cooked. Some patients, of course, would complain of fish breath. There are capsules, of course, for patients that don't like to eat seafood, or patients that have allergies to seafood. But as I say it right here, it's really kind of a good reason to kind of splurge and kind of go out for a nice lobster or salmon dinner. Okay. And then the other drug that's kind of not really a main drug, but it is out there, is Orlistat. Basically, it inhibits the pancreatic lipase, and it can be used to reduce triglyceride levels. Right now, Orlistat's indicated for weight loss. The side effects are kind of oily stools, loose stools, diarrhea. You can see a reduction in some of the more fat-soluble vitamins. But right now it is indicated for weight loss, and it does have profound kind of pancreatic effects, so that's why it's in this lecture. So a lot of these drugs basically center on combination therapy, and so you can combine these drugs in several situations. A few examples are listed here. When you see VLDL levels that are increased, you can, due to resin use, you can also see high cholesterol accompanying that. When there's both VLDL and LDL levels are elevated, when there are certain enzymes such as LPA and so forth, or HDL, that are deficient, and that kind of produces other hyperlipidemias. And so when there's kind of two targets at work, whenever you see alterations in VLDL or LDL, you can kind of guess that total cholesterol, of course, but at least HDL and some of these others might be affected. And so some of the more commonly encountered combination therapies include a fibric acid with a bile acid binding resin, a statin with a bile acid binding resin, niacin with the same. Niacin and statins have been used in the past, but I think probably the more commonly encountered one for the especially for like the cardiac patients, the post-AFib patients, patients with a history of stroke and diabetes, would be a statin plus Azedia or ezetimibe, and that's under two brand names, Vytorin and Liptruzit. And we're not going for either one of those to be better or worse than the other. They're both ezetimibe with a different statin, and so these are kind of the combination therapies that you'll see. Just to kind of put everything together, if your target is LDL, the most potent drug is going to be a statin. If you're not getting the most bang for your buck with statin as a monotherapy, you can kind of combine the statin plus ezetimibe. That'll offer the most profound reduction in LDL. If your goal is to reduce triglycerides, there's several drugs out there that can reduce triglycerides, but it seems like the fibrates kind of have the most triglyceride lowering activity by as much as 50%. The other drugs would be slightly below that. And basically the other drugs that exist outside of statins exist for the patients that cannot handle a statin, most often due to the muscle weakness and the muscle pain that's associated with long-term statin use. All right, so that's it for looking at drugs that affect lipids and cholesterol. If you have any questions, of course, please email.